and then we helped. When then our team will take all those samples that were collected from the volunteers, passengers, and then put them in one tube. One tube were containing 10 swabs. Then after that, because as you can see on this picture, the samples will be in a dry tube, in what we call it a conical tube, and then we have to add some solutions in order to have the solution to be able to get our virus. Then after we now get our samples with the PBS, this is the solution that we use, and we incubate them for 20 minutes to allow all the virus to go into our solution. Then after that 20 minutes is where now we do the RNA extraction. The RNA extraction is as a normal process as the other extraction is just using, here we're able to now to use the automated extractors. Then after that, we now get our RNA extracts, because COVID-19, we get what we call RNA. It's not DNA, it's RNA. After getting our RNA now, we can proceed with the PCR. Please, next. So the second approach, apart from the source pouring, taking samples from the passengers, now we go ahead and then start also collecting samples from the aircraft. So what we did here is just we use, as you can see in the picture, we use that device in that bottle. Those are the specific materials for wastewater collection. And then after using those devices, we will now collect only 1 liter of wastewater. After collecting at wastewater, all those works are done at the airport. The source pouring I presented you before is tested at the airport. But this one, wastewater, the samples are brought to National Reference Lab. So because those are waste, before bringing the samples to the National Lab, the sample will undergo the process of processing. They have to clean it. They have to make sure that when it comes to NLL, it will be well cleaned. So when we receive the samples at the National Lab, now we start other process. The process we start with is now to homogenize our sample. As you understand, the wastewater will have a lot of things. The solid materials, the liquid materials. So ensure to make sure that we have a good sample to proceed the extraction. We have the methods or have the things that we use to homogenize our sample. After having a very good homogeneous sample, now we continue with the normal extraction, the extraction that we use as the source pouring. But here, of course, the protocol will be a bit different. After now, we perform the PCR. So those two approach that we brought in, nationally brought in, it helps us now to monitor not only the variant that are circulating in our country, but also the variant that are coming in the country. And this has been successfully done, and it is being done even currently. Please, next. Next, please. So that was the part of PCR. PCR, we take it as like a screening test. But we also have another technique, as Lisa said, we go beyond and do some advanced genomics techniques. Here what we do, we take all those samples. The negative samples are kept in our lab for only seven days, but for the positive samples, we have a biobank for positive samples. So the positive samples now undergoes the sequencing procedures. Why do we do that procedures? In order to see what are the variants that are in the sample. It's not only on this, as I presented before, we have those techniques to look at the variant that's circulating in the country, and the sample, get samples from different clinics, but for the samples that are being brought abroad, we take samples at the airport. All those samples are received in a sequencing lab. After now is where now we do sequencing lab. So here this slide was trying to explain what do we do PCR? What is a PCR? A PCR it helps us. First of all, even before we go to PCR, we do what we call reverse transcriptase PCR. It is RNA. As I said before in my slide, our COVID is RNA, so we have to convert it in DNA, because the PCR techniques use only the DNA. They never use RNA. So to have the DNA from RNA, we proceed this with this technique called reverse transcriptase PCR. Then after that, we continue PCR. PCR is all about making a lot of copies from our DNA to be able to be detected by the PCR machine. After detected, then we can see the positive and negative. Then please go ahead with another slide, please. So now, as I said, once we have the positive samples, is where now we start doing the whole genomic sequencing. The whole genomic sequencing is started. I will go quickly. We have like four main steps in the sequencing, where we start again by extraction. We do another extraction, because in the sequencing, not all samples will be sequenced. We have to choose what are the eligible samples for sequencing. Our protocols tell us to only do samples with the CT value of 28 and below. Above those samples, we do not consider them. So what we do, the first step is to do extraction again, and then choose, after extraction, we do a PCR, then we choose what are eligible. Then after that, we go after now having the eligible samples, we go ahead and then again we convert our RNA in cDNA. After we go to this step, which is a very important step in the sequencing, we call it library preparation. The library preparation is the step which will help us now to do sequencing. Is where we are going to take all our samples, put them together, and then be able to put them in the sequencing machine. We have two platforms at National Lab, which is Nanopore or Minion, another one Illumina, and all those ones are next generation sequencers, and we use them at the same time. So then after like 4 days, the sequencing can take 4 days. Then at the 4th days is where now we're going to get our result. So our result will not come as positive and negative. It will come in a file that we call FASTQ file. That FASTQ file is the file that the bioinformatics team will now come and take in the lab and go do analysis with the tools. Those tools, as I said, we take you through the tools that we use to analyze this FASTQ file in order to see the final result. Please, next. So though we have now able to do a lot of work and most of the work was successful, we had some few challenges. For instance, the challenges was the CT value. As I said, we are only able to do sequencing of CT values below 28. And then we struggled to also, because those samples, the CT value above 30, also they have information that we like to know. So what the solution that Australia were now trying to adopt is now to try and optimize our protocols and see if we can now be able to sequence the samples that are above 30. Another challenge is the primers. We are not able to do our own primers. The primers are a very big component that are needed in a molecular lab. And we are not have the ability to do the primers. We always have to work with other institutions in order to have primers. But we are trying to sit down and see how we can now start having trainings, also do some practice in order to start now making our own primers. Another one is for the wastewater, as it has a lot of things in it, so we also we struggled to have the variant. We do a lot of runs that were not passing because of the kit we're using. We used the kit that was called Midnight Kit, and it was not able to give us a good result for the wastewater. Then we
I am so sorry. Hopefully, all right. Um, as I was mentioning, our model helps us to track the country of origin. So, for example, not to say that this is we have to like close our borders or anything like that. It's more of like just to awareness. It's an alert system. So, for example, here, let's say here you can see that the United Republic of Tanzania, the flights that passengers that are coming from there are having we're having more positivity. But just so you note that it just needs one positive case to make the whole pool positive. So it's not to say that there's a lot of people as well that are positive for COVID. So we have noticed identified different lineages. So for example, right now we're looking at we're watching okay. Hopefully this works. Um, Next, please. Yes. So we also, as she mentioned, we have two different type of samples we take. So we do also the wastewater. With wastewater, we kind of encountered a few difficulties because of the type of sample it is. And also it's hard to target, it was hard to target our SARS-CoV-2 as she mentioned, which is why we use different with the Arctic protocol so that we can have shorter primers so they can target different regions of the SARS-CoV-2 genome. And then we have like the first trial. It was the first week. It was really difficult to sort of the first run. Sorry, sort of failed. So we we changed the protocol, and we were able to identify some of the variants as well. So we have noticed the BA286, which is also under the watch of WHO, but the good thing about this is that you can have more variants in that one in that sample. So next, I will explain what it means. So we used this is apart from our pipeline. We also use different tools to sort of analyze our data. So for example, you want to understand, as I mentioned, in your sample you can have multiple variants. So we want to see estimate the abundance of that lineage. So we use this tool, which helps us to see how many lineages have been identified and what is their abundance. So for example, here we can see that the XBB.1.9 star is the most abundant in this sample that we have. Next, please. And then we also tried this other, it's a pipeline actually. It also sort of uses the same steps as our pipeline, but the only thing it does is that it doesn't do it based on alignment only, but it does it based on mutations. Because alignment, it can have a when you call for your bases, sometimes they might not align correctly, but with mutations you will know where in the position at which location the change has been made. And so this tool is really, really useful, and it also gave us, so what it uses an annotated, it annotates your variant calling file, and it also tracks the amino acid. These are the amino acids, meaning that at this position, the amino acid K has changed, and this is what it has changed to. So we need to know where our changes are, and the only limitation with this is that, for example, we don't have this file for all the lineages, so we can't identify a lineage. We can only predict which lineage it is, but based on the mutations. Next, please. So basically what we want to do is to apply our model, but go deeper. Go deeper and try to understand really above the genome, because right now we're on the level of genome, we're just looking at the variation of our SARS-CoV-2 genome, but we're not, we can look at also the transcriptome, looking at, and also looking at the protein interactions, as well as metabolites. And in order to do that, we want to really focus on increasing our data storage capacity. As I mentioned, it's very, very crucial, because it takes, doing this work analysis, it takes a lot of computing power. So we need a good computing infrastructure. And we are hoping with our partners that we will be able to do that. And we also want to continue to train in bioinformatics analysis, because this is very crucial to understand. You need the skills to understand and to analyze this data. Lastly, we want to also connect our genomic data with clinical data. And by that I mean that we're not only doing surveillance of SARS-CoV-2 with air passengers, but we're also doing it in the country. So we want to say the link. So meaning that if people are coming in with a variant, we will be warning, okay, we will see this variant spreading across the country. So that way we can also sort of relate it together. So thank you so much. I apologize, I went through it very quickly, but yes. We would like to acknowledge, next. Thank you. We would like to acknowledge, first of all, we want to acknowledge Reed's division for helping us to showcase our work. And we want to thank the Minister of Health, as well as our partner, Concentric by Ginkgo and CDC, for providing us with equipment and others. Thank you so much for helping. So as I mentioned, I'm moderating. I think it's better we just continue with all the presentations, and we'll have a Q&A at the very end. So please keep your questions to yourself, and then we'll go through it. So our next presenter is going to be Dr. Noel Gahamanyi. Please go ahead and have your presentation.
Okay, good morning. As she said, I'm Dr. Noel Gahamanyi. I'm the Director of Microbiology Unit at the National Reference Lab. I'm going to take you through this presentation about the molecular diagnosis of TB resistance to first and second line drugs using the line probe assay. It's a molecular biology technique that will detect resistance to first line and second line drugs that are used against TB. Next. This is the outline where we talk about the TB and the problem it causes. Also the TB diagnostic steps, also an introduction to this line probe assay. Then what are the level of resistance and how do we detect the resistance, and also the data we have so far, and also the way forward. Next. So currently TB is among the top 10 global public health threats. Actually it was second after COVID to kill many people. So in 2022, around 10 million people got infections, were infected with this TB, tuberculosis, and the deaths associated with it was 1.3 million people died due to TB. And also among the TB resistant, there is no more TB among the follow-up, because there are new patients and the follow-up cases to check if the patient is responding to the drug, to the treatment. So the drugs, as I said, we have first-line drugs. The common one are isoniazid and rifampicin, but there are others like pyrazinamide and ethambutol. Among the second line, if the patient, the pathogen he has developed the resistance to first line, he or she is treated with second line, including fluoroquinolone, like levofloxacin or moxifloxacin, or aminoglycoside like amikacin. Next. So the evolution of resistance, as I was saying, drug susceptible TB, when it is susceptible to the drugs, immediately the patient is treated with first line, including rifampicin, isoniazid, or pyrazinamide. But if the patient has a pathogen that's resistant to the first line of drugs, he's treated with second line, including fluoroquinolone and aminoglycoside. In case he's resistant to the two, he's treated, the patient, he or she is treated with very few options like bedaquiline. There are very limited options. So in case there is no, the pathogen is resistant to all, there is no treatment option. Most of the time the patient also may die. That's why we have seen cases of people who die with drug-resistant TB. Next. So among the drivers of this resistance, patients who do not complete their dose, prescribed dose. We have seen that the patient may feel better after some months, then they will stop the treatment. Or because also it takes long time, some 6 months, even times beyond, so the patient may get tired if the community health workers don't follow, make a follow-up, the patient may stop the treatment. That one will lead to resistance. Also, previous TB therapy, because if the more you take the drugs, your pathogens will get used to it and will develop resistance. Also, if you have been in close contact with a drug-resistant TB case, so it doesn't mean once you get a TB, it doesn't mean your TB will be sensitive to the drug. No. If the pathogen is already resistant to the first line or second line, immediately also you will need to go to the higher drugs. So if you have been in contact with such case, also it's one of the factors to leading to the drug resistance. Also coming from a region with drug-resistant TB where they are common. It's said that like in Africa and also Asia, they are among the endemic regions. So if you are coming from that area, also may be prone to develop resistance, to have a pathogen that is drug resistant. Also among HIV patients who have a co-infection with TB, also for them there is that risk of developing resistance. Next. So in diagnosis, normally a sputum is taken and then checking through the microscope by staining, then checking to the microscope to see the acidiphilus bacilli. If they are detected, then we go on with culture, on solid and liquid. Then we move on with the phenotypic DST. DST is the drug susceptibility testing. So you check now, is this Mycobacterium tuberculosis sensitive to the drugs that are used phenotypically? But there are also molecular technique that you can go on directly. The one that I'm talking about today is about this line probe assay among the molecular technique. There is another one called GeneXpert. It's also commonly used. But this GeneXpert, it only detects the resistance to rifampicin, while for line probe assay, it can detect both resistance to rifampicin and also isoniazid. Those are the abbreviation R for rifampicin, H for is isoniazid. So, but it's also possible to immediately go from sputum without passing through the culture. You can also go directly. This is so quick. You can get the results in just a few hours, like 2 to 3 hours. You can get the results. But there is a risk that the more you go directly from sputum, you may get less chance to get it because once you pass through the culture, you are increasing the chance because you have colonies. But from the sputum, the load is still low, so to detect it is not always 100%, but it is possible. Once the patient has a lot of Mycobacterium tuberculosis, you can even detect it without passing through the culture. Next. So this line probe assay, it based on the nucleic acid amplification. My colleague Esperance talked about PCR, polymerase chain reaction. So it's a technique that is used to make millions of copies of a small amount of nucleic acid. Here we are talking about DNA. For her, she was talking about RNA like SARS-CoV. It's an RNA virus. But both are nucleic acids. DNA and RNA are among the nucleic acids. So it amplifies that small amount of DNA to many copies that can be detected. Once you have many copies, you can now detect the gene mutation. It's like now we are talking about rifampicin. Which gene do we check? RPO, RNA polymerase. Those are the genes. For rifampicin, to know if the pathogen is resistant to the drug, to rifampicin, we check the gene called RPO, which is the RNA polymerase. So the RNA polymerase, when there are mutations there, okay, it will prevent the drugs from acting. The second drug is the isoniazid, CAT-A. This is a CAT gene. It is catalase. Also, it's an enzyme that will do detoxification because it will remove the peroxide. Quinolones, there are many drugs like levofloxacin and moxifloxacin. We check in the gene called the gyrase. DNA gyrase, it removes what is called spacoiling. When there is DNA replication, the DNA gyrase helps to remove those spacoils ahead and after the DNA polymerase have passed. We have also aminoglycosides. I talked about amikacin and kanamycin. Those are among the aminoglycosides. So also the gene that is detected is the 16 sRNA. So it uses the polymerase chain reaction, but there is, after PCR, there is hybridization. For Esperance, she talked about after PCR they go with sequencing, but this uses the hybridization using probes. It means the DNA, there are DNA that is labeled, attached to the strip, then you add your sample. If your sample has the corresponding mutation, it will go and bind to that specific region. Next. So this is the step for this LPA RNA probe assay, where from the colonies you got, you do DNA extraction, and from the DNA extraction, you do amplification, which is PCR. There is also labeling of the fragments, so that you can detect, you receive the signal at the end. Then there is that DNA strips that I was talking about. Then labeled amplified DNA fragment will bind to the probe, and you receive signal. If there is that mutation, you receive the signal that will tell you this pathogen has this resistance. Next. So then click next. Okay, you do as I tell. So this is like the way we interpret the result for this RNA probe assay. So there are different bands. Like the one now in red, they are the control, which will tell you like the complex conjugate. And so first of all, you should get the bands for these controls. Next. Then, once you get the band for the mycobacterial tuberculosis, you will check now the genes. You see that there is RPOB, right, polymerase. There is that CAT-A, CAT-G, sorry. Then again, next. Also this, that's RPOB, next. And those are the three genes that are mainly targeted. If you find the gene for RPO, this for RNA polymerase, you see the WT, this is the wild type. If you find any band among those black ones in the WT, it means it will be sensitive. So the pathogen is sensitive to rifampicin. But if you see any band in this region of mutant, it means that the pathogen is resistant to that drug. Okay, let me take a simple example. Let's take the number one. These are different samples, 1 up to 5. Let's say, take number 1. Already the control is okay because you see the black bands. RPOB, you can see the bands, but there is no band into the mutant, so all are white. And also, no band for this cat. Also no band for INH in the mutants. So it means that this pathogen is sensitive to rifampicin and also is sensitive to isoniazid. You can take another example, like let's say number 3 now. So this one, it is sensitive to rifampicin, but it is resistant to isoniazid. Why? Because you can see the band among the mutant, the isoniazid mutant band. So this is the way we interpret. Next. So second-line drugs, they are important for optimizing the treatment. Sometimes you go on them in case there is resistance to the first line. Next. So this is the band for second line. As I mentioned, among the genes, we have the guylase A and guylase B. This is for DNA guylase. So if you see a band there among the mutants, that is the trick. If you see band for mutant, it means it will be resistant. If you see only for the wild type, it means that the pathogen is sensitive to the drug. Next. You can go next. So among the samples we have processed last year, from January to December 2023, we have seen that, okay, in general, among the 381 samples we tested, 345 were sensitive to both isoniazid and rifampicin. While 19 cases had monoresistance, it means that they were resistant to only one drug, including which was isoniazid. We didn't find any resistance to rifampicin. While for 17 isolates, they were multi-drug resistant. They were resistant to both rifampicin and isoniazid, meaning that for those patients, they had to be treated with second line, including, as I said, like amikacin or levofloxacin. Next. So line probe assay is a technique that helps us to track the level of resistance. Sometimes we use it even without passing through the culture. I didn't mention it. Normally culture may take even above 2 months. But the patient should be started with treatment. So how do we know if the patient is responding or if the pathogen is not resistant to the drugs? We use a molecular technique which can tell us the level of resistance. But it can go concomitantly or in parallel with the culture because you have the low chances to get it if you go directly to the molecular technique. And also, we plan also to do for sequencing for the other genes because sometimes you may see, you may not see the resistance using line probe assay, but because there have been mutation in other genes. So like whole genome sequencing can tell you now which genes, for example, there are some efflux pump genes that may pump the drug out. So you may find that the rifampicin is okay, but if the efflux pump, they are not okay. So better to check many genes, but this is for research, not the routine. And also, we are supporting studies that is checking for this amikacin, which can help, is among the second-line drugs. There is a clinical trial that is ongoing to check if there is enough sensitivity, it can be included into the treatment guideline or the algorithm in Rwanda. Currently, we are using this rifampicin, isoniazid. Sometimes also go to the second line, but not on a routine basis. We don't see, in general, we don't see the resistance to second line drugs. Also, there are other initiatives like to check now the presence of TB in stool samples among children. Normally, we use sputum, but because the children, they are not able to produce sputum, there is a protocol that we are trying, where it is still in its infancy, to check presence of mycobacterial tuberculosis into stool among children. Thank you for your kind attention.
Thank you so much, Dr. Noah, for taking us through this very, very interesting talk. Now we'll have Emmanuel Kabarisa who will do the same, but focusing on HIV drug resistance. Please come on. And also try to check on me because I'm giving you the time.
Okay, good morning. My name
enough concentration to be tested? And is there any in the data that you find, is there any correlation with seasons, like the season? I can say that, for instance, now we have so much flow. Is there any correlation between your findings? I know that you have distribution where they're coming from, but again with the seasons. Thank you.
Do you want to answer the question on But to answer on the thing on epidemiology, I told you that the next step is to sort of link the data on epidemiological data on not only just SARS-CoV-2, but also respiratory diseases such as influenza A and B. But in terms of the concentration, I think maybe she would have a better answer than me.
So thank you, Joel. The pooling does not really reduce the concentration. When a sample has a very high CT value, it will still show in the pool. The pool will still have the high CT value.
Does that answer your question? Okay. And we'll also invite you if you want to come and see how it's done. You know, why don't you come? You're part of us. Any other question? Last minute question? All right. We can go back. All right. Thank you so much. Quarity, please go ahead and present.
Okay, good morning again. My name is Quarity Emmanuel. I'm the director of immunovirology unit at the National Reference Lab. So I'm going to take through this presentation, which is on molecular monitoring of HIV drug resistance. Next. So as overview, since 2016, we had this policy of treat all, to mean the people with diagnosis with HIV positive, they have to go through the treatment. And every 12 months, these people have to have the viral testing. And why this viral testing? This viral testing is indicate if the people they are suppressing or not suppressing. So next. So we had like 3 lines. We have the treatment on first line, which I'll say they are the tenofovir and the lamivudine, but with combination of some also antiretroviral. We have the second line with zidovudine and the lamivudine. So next. So why we have to do viral load? I said that it shows if the people they are suppressing or not suppressing. So and our cutoff is 100 copies per ml. But when we see that the people they have like over 100 copies per ml, maybe they don't suppress because of their adherence, or maybe it's because of some mutation which are resistant to some anti-retroviral treatments. This is an example for 2016, where we had all people around 85% were on a treatment, and only 15% were not on treatment. Next. So as I said, when we have the patient with 1,000 copies and above, they're not suppressing. Maybe because of the adherence, bad adherence, or maybe because of the mutation. So before to go to the genotyping, we have to eliminate the case or the cause of the adherence. Then we have to go to the mutation detections. Next. So at the NLL we have 2 types of machine. We have this old machine since 2011 that is using for which is called genetic analyzer, which is used for Sanger sequencing. It's not next sequencing. It is Sanger sequencing, which are used for detecting the mutation for HIV, sequencing for HIV. But recently in December also we acquired another second machine, so that we have like a backup of 2 machines only which serve the whole country. Next. So as I said, when we have the samples, when we do the sequencing with the sample that are eligible, we have to evaluate the DNA of HIV. So we pass through the PCR as my colleague represent, and then we analyze the sequence. So and up to the 10%, sometimes they have this for overall for our results, the 10% they have this mutation, but the others like 75 to 92% up to date, they don't have mutation. They are on no first line. So next. So as we have a different type of antiretroviral treatment, as we saw on this NLT, it means necrotic retrotranscription treatment inhibitor. On this, we have this gene, which called K70E. It's predominant when you see on the curve. That it's predominant on NRTI. Next. So for non-necrotic retrotranscription treatment inhibitor, we have this gene called the A98G, which is a predominant. And this data is only for the year of 2022 to 2023, July to June. So next. So for the protease inhibitor mutation, which is the dominant is the L33F, which is around up to 3%. So next. So as key point on this drug resistance or HIV, so this resistance developed in the setting of inadequately suppressive RT treatment. So we have to indicate our patient that they should be on good adherence of the treatment, because we are receiving some samples which are eligible for sequencing, but over 95% they don't have mutations, mean they have some bad adherence of the treatment. So we have always to eliminate the issue of adherence, and then we have to consider the test of resistance when we are sure that our adherence is good for our patient. So, and the resistance need to be interpreted with caution and the ideally with expert assistance. Because to take the patient from the first line to the second line, we have to pay attention to make sure that this person have a good adherence, but it have a mutation. So we have to pay attention on this interpretation of the results. So next. So thank you. That was my presentation.
Thank you so much, Emmanuel. Can we have maybe one question for our presenter? Yes, please.
Yeah, thank you very much, Quarity. I would love to see maybe some data on even on the drug resistance in Rwanda, especially, and also to see how we are handling, because we know that we have some drug resistance data that we are collecting from the lab, and how they're being centralized from like all those hubs, and maybe also like what kind of mutation that we have. And we also be interested to see is like time on treatment important, because as of now we are having people who are getting on pre-exposure prophylaxis, and they are starting already when they get infected, and they are getting resistance even before they start treatment. So we'll maybe next time will be it'll be interesting to see some key data, and maybe the last question will be, how can we ensure that we are putting together all the data? Because data from drug resistance, as much as I know, it were not like they were not collected and saved in safe storage. So maybe accessing them and use them will be an opportunity here to look at mutations and inform the program. Thank you.
Thank you, Eric, for this good intervention in the question. So one we need, we started to do this drug resistance for HIV since 2011. Maybe it will be good and maybe will be supported by your division to have like a tool that you have all those data from 2011 up to date. Then we can evaluate this resistance by maybe by year basis, or maybe we can track those resistance. Maybe we need the tool. That's one. Second, this from 2011 up to date, we are having only one machine, which was serving the whole countries. So, and you know, those sample, they have time of stability. Normally the sample for Vile Road is stable. When we are doing the transport, it is 24 hours. So can you imagine the sample from Rusizi up to Kigali? Maybe with the change of temperature, it can also affect the life of the virus. So, but today, we are trying to optimize the transportation of the sample. Then when you arrive at the end, we are sure that we are testing the real virus. So what we want to do, as I said, we want to eliminate this problem for the adherence. Then also the second, to optimize the transport of the sample, the stability of the sample, so that those mutations can be detected in real time. So thirdly, maybe about this PrEP, we can plan to see some cases and to follow those people who have been on PrEP, and after they become positive, they become infected, to see the status, if maybe at that time of PrEP, they develop the mutation. So that also is like in the future will be a good study. Thank you.
All right. Before we go on, also we are planning to publish soon our 2022-2023 report. We will have more in-depth information on each division and what, like, the data trends that we're seeing for the diseases we're monitoring. So next we have Etienne Kaidi, who's going to present on anti-TB therapeutic drug monitoring project. Please comment.
Yeah, thank you. I'm going to present on anti-TB drugs, therapeutic drug monitoring. Anti-TB therapeutic drug monitoring is a new technology that comes to complement from what Dr. Gahamanyi was presenting. In case you have, you have a poor treatment outcome from a patient, yet in the lab you don't have resistance. This is how therapeutic drug monitoring can come and intervene to personalize the dose. Because as you know, the dose we used to take as in medicine is the dose from the general population. But people are different. So the general population conclusion may not work to Etienne for a specific drugs. This is how therapeutic drug monitoring can come and intervene. Next. Yeah, as we can see from this 2023 WHO report, but this data was collected in 2019, TB is among the 10 killers, the 10 diseases which kill many people is actually the seventh disease to kill many people worldwide. Next. So since 1940s, scientists, TB is an old disease. Since scientists come up with a solution to TB disease or TB infection, where many drugs has been discovered and tried, but since 1980s, This is where the first line treatment line, which is actually being used, isoniazid, rifampicin, and pyrazinamide. This is a treatment used for the first line in case any patient is diagnosed with TB infection. Next. So even though the drugs, the treatment is there, but we are still facing different challenges in TB management. Most of the three challenges faced in TB management. The first one is drug resistance. Drug resistance, I will not come back on it because Dr. Noel provide more information on it. There is recurring infection. This is where a person can get an infection. He gets the 6-month treatment. After the 6-month treatment, sometimes he's declared cured, but after sometimes he come back to the health facility. He's again diagnosed with TB infection. Yeah, the last one is drug toxicity. As we are different in different things, even the people are different in the metabolism of drugs. Some people may have drug metabolism, which may help them to work in a general condition, but other people, as they are different, some people may metabolize quickly the drugs. Instead of the general population dose to come effective, it leads to the toxicity. So next, as I was saying, I wanted to share with you, this is a case scenario from the data from our TB division, where a man with 74 years old who is HIV negative, he got a recurring infection of TB 7 different times. The first time he was diagnosed with TB in 2009, sorry. In 2009, he was diagnosed with TB infection. Then he got a treatment. After he was, in June, after 6 months of treatment, the patient was declared cured. But after 8 years, the patient got again TB infection. So he got the treatment. In October 2017, he was again declared cured. In 2018, he got again, he got again diagnosed, he was also again diagnosed with TB infection. He came for the 3rd time on the treatment. And in all of these cases until in 2020, this patient was still drug susceptible for the first line. So the challenges like this one, this is why we came up with a solution which is to quantify the drugs of anti-TB first line in the blood. Next. Yeah, the method, the new innovative or the way forward to come up with a solution to these people is the therapeutic drug monitoring. So once you have an infection and you fulfill the inclusion criteria, as we will go through, we will see the inclusion criteria. So if you fulfill the inclusion criteria for TDM, we collect the blood from you. The blood is analyzed. Once the lab got the results, the quantity of a specific drug in blood, these results are transmitted to clinical pharmacists. The clinical pharmacist with the clinician sit, analyze the patient results, then decide to optimize, to adjust the dose to the specific patient. Actually, there is two different way forward. You can use either conventional. The conventional is the where you can analyze the sample and the analyzer give you directly the results. The semi-automated is where once you get the results, the lab scientists analyze the data from the analyzer and interpret the results, which is the quantity of the drugs in the blood. Next. So, currently, with this TDM, this is a project we started in 2021. Yeah, the current status, currently we have key equipment to do the therapeutic drug monitoring. At NRL, we have an HPLC Infinity 260, which has 3 detectors. We have a fume hood and the concentrator. Others are miscellaneous equipment and consumables. With the support of URA team, we managed to develop and validate a TDM method for the 3 first-line TB drugs, which is isoniazid, rifampicin, and pyrazinamide. We also develop a sample collection protocol and a sample collection form. Currently, we have managed to conduct a pilot phase in Kigali, where we managed to collect 62 TDM blood samples. Next. This is a HPLC, I was saying. This is an analyzer which helps us to do the semi-automated TDM. Yeah. As I was saying, these are the eligible criteria for TDM for anti-TB drugs. The first one is when a patient is still positive at 2 or 5 months of the treatment. The second is when the patient has HIV/TB co-infection. The third criteria is when there is a relapse. A relapse is when is like the scenario I showed you in the previous slide, when a patient was diagnosed as TB, as having a TB infection, then after completing the 6 month of treatment, the 6 month treatment, and he's declared he's cured, then after some time he come back with the infection again. The fourth criteria is different chronic infections like hypertension, diabetes, cancer. These are the 3, but if there is any other, the person who collected the sample has to specify. The 5th criteria is when the patient previously was treated with TB infection. Either he failed on the treatment. This is a case of having a positive control for the 2nd and the 5th month of treatment, when he has a relapse, or when the patient return after loss of follow-up. Next. Yeah, let me go. Yeah, this is the 3 sites. This is the 3 sites for the pilot phase. We have Remera Medicalized Health Center, Biryogo Health Center, and Kurunum. If you can see, the most people eligible for the sample collected, males represents 50 out of 62%. Yeah, next. For the eligible criteria, if you can see, HIV/TB co-infection represents the high number of people coming for the TDM. Next. Yeah, in the future plan, once we sustain the TDM for anti-TB, we have in the future plan, we will do TDM for psychotropic drugs, we will do TDM for cardiac drugs, we will do TDM for organ transplant, we will do TDM for HIV drugs, and TDM for cancers. This is a long journey for the therapeutic drug monitoring. Next. Yeah, we have challenges. Challenges, the first challenge is capacity building in the health workers team. So as you see, to have this program attending it is objective, we need to have lab scientists trained on the therapeutic drug monitoring. We need to have pharmacists and clinicians. Why am I saying this? Currently, out of these 62 samples in the lab, we managed to analyze and come up with the results, but uh, unless there is an emergency where we get a technical support for dose adjustment from WHO experts. Otherwise, the results are not used, because we generate lab results, but we don't have clinical pharmacists trained in therapeutic drug monitoring to advise on the dose adjustment. What we can come up with as a result, we can know this person has low quantity of drugs based on the reference range on a specific drug, but we can't go beyond, because the clinical pharmacist and the clinician trained in therapeutic drug monitoring are the one to sit together and decide based on the clinical manifestation of the patient on the dose adjustment. Yeah, this is the first. The second, as this is a new technology, as this is a new technology, even getting where people can be trained is an issue. This is why we really need advocacy to have at least one reference center for TDM for these anti-TB drugs. The one we tried to contact even is in Netherlands, but until now we didn't yet get the support. Next. Yeah, we do acknowledge to RBC management for making this initiation of this project, and also URA team and management for their technical support, because they are the one who helped us to make this happen. Thank you.
All right, can you hear me now? Perfect, thank you. Yes, let's move to the next one, and our last one. Please come in front, Dr. Edo. Go ahead. You have a thing.
Rakorana. Ntabwo ari ibiriho. Good afternoon, everyone. So, as you see, there is a different presentation happened, all of them regarding testing, either molecular, either genotyping, either HIV, TB. It requires one thing, which is quality. Is what I'm going to present as Dr. Edward Ntagwabira. Okay, so the quality I'm talking about is going through accreditation. And the National Reference Laboratory, RBC BIOS, has already started accreditation and are accredited to comply with those quality I'm talking about. To make sure those kind of testing, HIV, COVID, and others are comply with the quality. So, what is accreditation? Many people understand about accreditation. National Reference Laboratory has been accredited and also recognized as COVID testing in the region. So, it's a procedure in which authoritative body give recognition that body or person are competent to carry out specific test, meaning that they are competent to carry out HIV, to carry out COVID, to carry out TB, and so on. Those are accreditation and must refer to ISO 15189. So what is the benefit of accreditation? Why we have been traveled to get accredited? So the accreditation is to strengthen and to check the gap in the laboratory process. We are supposed to identify the gap so that you will know how to improve and where to improve and when to improve. So accreditation also should involve the quality and the safety in the laboratory. Quality is a requirement to ensure all those results provided are accurate, are reliable, and also respect turnaround time. And also accreditation reduce the risk and also reliable cost. If you are accredited, you are supposed to follow the quality management system to ensure all those results you are providing to patients, they are accurate, reliable, in a timely manner. And then the accreditation has been allowed Rwanda to provide internationally recognized COVID-19 testing, whereby the people who were supposed to travel, for example, in Dubai, were supposed to come from Nigeria, to come around the countries to be tested in Rwanda due to this accreditation. Now you see how the accreditation is requirement. So what is equality? At the beginning, I talked about equality. I was telling you, all of those presentations, it requires to comply, to fulfill this quality, to ensure the accuracy, and also to ensure the customer are satisfied. Patient care is requirement based on the quality. So the quality is a degree in which a set of the required testing standards are complied. There is a certain degree required in order to ensure our quality is appropriate. Achieving quality results, those are the three things we need in order to ensure the National Reference Laboratory is providing someone who needed to travel outside with COVID result are acceptable in the US, in France. Do you remember during the COVID, some aircraft has been arrested, except Rwanda. It is because of this. If I talk about accurate, reliable, and timely is requirement to ensure our record in the laboratory. So, in order to have this quality management system block, there is some block complementarity which is required to ensure the quality management system is in place. So there is 12 quality essentials, whereby must be started from pre-test, test, and also post-test, which is called pre-analytical, analytical, and post-analytical. Those are organization, personnel, equipment. So you cannot have a quality, as Kaiji said, if you don't have trained people. So if you are not organized, you will not comply with the quality. Equipment without maintenance and calibration, they cannot give you the accurate results. The reason why those channels must be respected. Continuous improvement is also required, because you can start quality control, quality management system, but if you don't monitor, assess, to make sure the system is continuously improved, it will not comply. Customer focus and also facility safety is requirement. All those, if one is missing, there is no quality there. So, in order to comply with those quality management systems to be in place, we need also technical team to collaborate very well with management team. So, the reason why management, we need for them to provide financial, to train a personnel, also to have calibrated and maintained the equipment, and also this problem of supply. It's still there. That is our challenge. So as long as we start presentation, let me appreciate this organization of this scientific presentation. Somehow we get solution for this one. Okay, what is ISO 15199, whereby National Reference Laboratory and the other laboratory has been accredited for? So, ISO 15199 is international standard and for medical laboratory requirement for quality and the competence. You need to be competent in order to comply with the quality. So, before National Reference Laboratory has been accredited on ISO 15199 2012 standard, which was quality and competence based for the compliance to international standards. The result you found at National Reference Laboratory, when you send outside America, France, anywhere, we are supposed to have the same result, which is standard, international standard. So now ISO has been changed. I'm not going to delay on this. So only some change has been added. So the major challenges, it has been revised. We are requested, we should comply with this ISO 15199 20 to help now, which has been revised. So those are the major challenges. Also the challenges is on line with those ISO 17025, which is general testing and the calibration of equipment. This one is no longer 17. It has been also revised, is 2020. So we need also to comply with this ISO 22870, which is point of care. In this new ISO, we need to comply with also point of care. Customer care satisfaction is requirement, and emphasize reduce of risk management. It has additional on this new ISO. So when the laboratory accreditation journey, so it's not easy to get accreditation, but it's a commitment. As I say, for management, technical team, it has happened in National Reference Laboratory, so whereby we has been accredited. So it has been started. That is a journey, as you see. We started in 2009 with support of the WHO Afro, whereby it has been launched in Rwanda, Serena Hotel. Then in 2010, accreditation process started with strengthening the laboratory management toward accreditation, which is called Salamata program, which one it was a journey, many requirements. So 2011, 5 laboratories were enrolled in the first cohort for accreditation process. So in 2017, every year, from that year, 2012 to 2017, we are supposed to add more laboratory to go in this Salamata program, which is a quality management system, is a requirement now. Accreditation cannot be always get by laboratory, but quality management system is the requirement. And then you will select eligible laboratory to be accredited. So those are the steps now in order to be accredited at National Reference Laboratory. There is required a lot of document. Develop and implement successful quality management system. There is a managerial requirement, there is a technical requirement, there is a lot of document, quality manual, safety manual, client handbook, and the others. So, and then we select accreditation body. By now, we have KENAS as our accreditation body. Then you conduct a self-assessment in order to know, I'm ready to apply for accreditation. Then you submit application to accredited body. After that, the accredited is come to do the baseline assessment and give you some non-conformities. After that, you work on it, you take a corrective action, and then they come back, they accredit you. After that, after accreditation, you need to have sustainability plan to ensure you maintain your accreditation. Okay, so those are how the Salamata was working. So there is a score and the stars. We started by 1 star, November, February, it was just step by step. whereby we are supposed to have at least this 85 to 94% max, so that we can start thinking about. But 5-star, if you reach here, you are sure you are accredited, and then you need to maintain the accreditation. So, National Reference Laboratory mission and vision, especially mission, is to strengthen and to support the laboratory network. Also, for them to have this quality management system in place. So we start helping them. All laboratory now, they have this quality management system in place, but they are not accredited. But there is two, which has been well supported by National Reference Laboratory and now are accredited. Rwanda Military Hospital, which has been accredited in June 2021. Also, we are not looking only at public health facilities. Also, the private laboratory has been supported because all of them, they are looking for Rwandese patients. So in April 2022, Legacy Private Clinic has been also laboratory accredited. And now we are continuing supporting the laboratory for all of them to have this quality management and to be accredited. So we do assessment. We look at those one who have more marks, and then 9 laboratories now already enrolled in the accreditation process to have this accreditation. So CHIB now is on the top, whereby it has already doing themselves assessment, and National Reference Laboratory assess them. After that, they are applying for baseline assessment from accredited body. After, when the accredited body will come, so soon they will be accredited also. So those are challenges, as you know, including National Reference Laboratory, no space, but we hope NHLS will be ready soon so that we cannot complain about it. So we have not NRL only and the other laboratory in the network. There is the old infrastructure also, which is the problem. And also I was talking about this problem of the tender process, supplying process. Even we are not able to pay external quality control, which is make us to know what we are doing is international standard requirement compliance. So those are also maintenance issues because of tender process. So as many presentations will happen, sometimes I hope you will invite also our high managers to come and participate so that this kind of challenges can be resolved. So, where forward? Where forward is just as we are moving from ISO 15199 2012 to ISO 15199 2022. We are supposed to prepare a gap analysis between this ISO and the new one revised. After knowing the gap analysis, we need to prepare implementation of transition plan for this new ISO. After that, we review all documents in order to comply, because all document we have has been applied with this in all the ISO, so they are supposed to be updated. Then the next, we'll continue to select this, to monitor this new 9 laboratory under accreditation, assess them, help them, for them to be accredited also. Thank you. Question, comment, please welcome.
Let us thank all our speakers for today. Thank you so much for, can you hear me, Andre? Okay. Thank you so much for all the presenters. And I think what we've learned here is that timely diagnosis will help with precision medicine, will help with treatment, will help with understanding what we have in our region. So thank you so much for everyone. I think we can take one last question to just wrap it up. If for the last 2 presenters, does anybody have a question? Yes. Okay. And okay. Yes.
Do you plan to publish the result of the
So the question is if you plan to publish anything on the anti-TDM project.
Once we get, yeah, we will publish it, but once we get the other technical part which is missing. Yeah, because currently it is partially done.
All right. So thank you so much, everyone. Please give yourself a round of applause. Thank you.
Thank you so much, Raisa, for a good moderation. Let's clap for her as well. Yeah. So we are really glad to see the team from National Reference Lab to be on board for this platform. And we are very privileged to say that we'll be happy to include you in the ongoing thematic research group that we are creating. Maybe Dr. Eric will touch on that. And for me, I summed my questions, and I would like to maybe raise it quickly, and based on the response, I will provide some of the way forward. The first one, can we say that based on your presentation and Esperance, NG1 is the variant of concern today in Rwanda, according to those data of 133 cases of 2024, yeah? Which is?
Different. Right now, we just were tracking it because we are looking as well as to what are the variants of concern and interest in, according to WHO. But the most important is to see where does it start to come in, and does it increase over time. But we are not focused on like which one is the most prevalent variant in the region.
Okay, it's just the monitoring for our country. Good. And another question was for SP. I got confused.
That question, yeah, that question was not for wastewater. It was like a general challenge we have. It was not related to only wastewater. Because as you say, the wastewater has, the kit comes with the primers, or there's primers that are already synthesized. That challenge is not for the wastewater. It's a general concern that we have. Thank you.
HPHC machine in drug pharmacy to be able to perform pharmacokinetic studies, and we were a bit skeptical to know if our HPHC. I knew that we have HPHC machine, but I don't know the status of calibration to meet the GCRP standard, good clinical laboratory practice, and this is linked with Dr. Edwards' presentation. It's good to see the progress you made for accreditation. It's a good success.
The HPLC is there, and we have maintenance contract. So the maintenance contract covers everything.
I think it's okay. I think as we have this maintenance contract, the requirement for equipment is just to be maintained and calibrated. So as we hear that from today, I'm going with the team to think about it and to see how. And we will require some involvement from you to understand what is requirement to comply with this HPLC accreditation.
Thank you very much. Over to you, Dr. Eric, to do the final remarks. Thank you.
Thank you all. This was a really good start of the year. So we had some challenges, but I need to say thank you very much to the lab team. And also just to thank Raisa. She pushed a lot to have this session. And when we see the quality of the slides that was presented here, it also shows the quality of the work that's being done in the lab. So this platform is about science innovation. I haven't seen any paper that you said you complete from the lab perspective. I didn't see any of them. Okay? And I'm wondering how would be the presentation from the lab person different from the one from the program? Because the program designed the guidelines, you have followed the guidelines, but you are here to discover and not to follow the program what they should change. And that should be through data. I like the way of presenting data. But to be sincere, I didn't see any paper, I didn't see any analytics. So it's a challenge that maybe to facilitate, and we are here to help moving forward. So this was a kind of sharing experience, different works that we are doing, but and I'm thinking that this could be a good research group in basic sense. But let's see how they put together some papers and also some analytics. As a follow-up of this session, and first of all, I need to apologize for the IP. We couldn't make it, but we wish to collaborate with our team. Background. NDSC. Yeah, I was mentioning that we like to collaborate with the reads so that we have like because we took videos and we have these presentations on YouTube. But as a way forward, we like to see and to create like a research group and identify some topics from your presentations that we can start with and write small manuscripts and have them published. So all the good works that we're doing here, if you don't share with the world, it means we are doing nothing. No one will know what we are doing if you don't publish them, if you don't share with the scientific world. So then, thank you very much. And this was like the first session of the year. And we hope that like as next time when we hear from the lab, we see papers that are published from the division. So Reeds is here to support Dr. Clarice and others, and we thank you for your time, for your efforts, and also for your good work that we have seen shared here. And I'm really sure that there are even others which were not presented. So let's work together to have them out. Thank you very much. Can we have a group photo here?
Yeah, sure.
Hmm?
Today, no snacks, but
NCDs out.
we are ending NCD.
New Year resolutions.
Eh?
We are vegetarians.
Can we have our team members, Kenny and
Yes. Yeah, yeah. Hmm? Hmm.